conducted by Department of PMR SVNIRTAR under the aegis of IAPMR and APMRO. Today's topic is something different, which is normally not discussed in our conferences or in our CME programs. This topic is basically very much useful for the students appearing examination for the practical point of view, or the faculties who used to teach about orthosis and prosthesis for the students. So we'll go through the basic things regarding the basic parts of the prosthesis and checkouts and common gait deviations seen in case of above knee prosthesis users, and how to detect those things so that you can suggest your prosthetist to correct the deviations in the socket or knee joint so that the gait can be appropriate. So check out a transfemoral prosthesis. That's amputee's ability to use prosthesis needs special attention. As I said that when we prescribe a prosthesis, we sometimes look for the K level of the patient. But if the prosthesis is appropriately fitted with the appropriate stump, then we can improve the K level of a patient. So the how the patient will behave as per the K level is concerned, whether it will be a community ambulator or a home ambulator, it not only depends upon the patient himself. There some extent related to us that how best prosthesis can be fitted to improve the K level of a amputee patient. So this depends upon a better design of a prosthesis with a better material, new prosthetic components, and latest fabrication and fitting techniques used for a different prosthesis. Basically, two types of prosthesis we use in clinical practice. One is conventional or exoskeletal prosthesis, and second is endoskeletal prosthesis. So far endoskeletal prosthesis are most advanced form, and to the endoskeletal prosthesis different components of the prosthesis are available, like different types of socket, different type of knee joint, different type of foot. All these things decides that the quality of the prosthesis and functional ability of the prosthetic users. So basically these advanced prosthesis are endoskeletal in nature. They are very lightweight, and addition of a polycentric knee joint improves knee function and stability at the knee joint, and superior cosmetic appearance, the acceptance of the amputee increases with that. So all these things matter. So as far as the gait deviation is concerned, so basically the two different parts carries importance in this case of AK prosthesis. Is the most important part is the socket, which receives the residual stump of the amputee, and knee joint. These two things are most important things which has direct relation with the gait deviations. So let us, before going for gait checkout part, let us discuss something about what are the sockets available for a transfemoral prosthesis or above knee prosthesis. So basically two types of sockets are available. One is a quadrilateral socket, another is ischial containment socket. Quadrilateral socket is the old type of socket, mostly used in case of exoskeletal prosthesis, and where the lamina, the oven and other modern techniques or facilities are not available for prosthetic fitting. So that's why this quadrilateral socket is very commonly used for the exoskeletal prosthesis. If you look to the design of this quadrilateral socket, it is a name says quadrilateral means there are four walls, four walls, one medial wall, lateral wall, anterior wall, and posterior wall. If you think that this is lateral wall, this is posterior wall, this is anterior wall, and this is medial wall. So for this socket, the anterior wall extend up to the trochanter, not to the tip of trochanter, it is to the trochanter prominence level, and there should be a gluteal clearance bulge which supports the gluteal bulge, and there should be ischial seat over here, and medial side should be, there should be adequate clearance for the perineal clearance, and there should be this is for the your adductor roll area to give clearance to the adductor roll, and this is area where the rectus femoris muscles has clearance. So this socket, though it is old design, still has a good biomechanical property, having a good weight transmission from this stump to the socket. This socket is basically the decrease in dimension of anterior to posterior in comparison to medial lateral. The reason behind is that if this bulge for the scarpa's triangle that is on the anterior wall, this pushes the stump posterior wall so that the ischium will sit over the ischial seat over here. The ischial bone will sit over the ischial seat. So this is the reason why the anterior posterior diameter is normally less than the mediolateral diameter. And there are, these are rectus for the rectus femoris clearance, this is the ischium seat, and this is gluteal fold clearance. Basically these are the weight bearing sides in case of quadrilateral socket. But if you look to the most advancement form is the ischial containment socket. This is bit different from the quadrilateral socket, because the most of the weight bearing in a ischial containment socket is the almost all four walls, the medial flare, lateral flare, anterior flare, and posterior flare. So whole stump, it can, you can say it is a total contact type of socket. The weight passes through all around the all flares of the stump, and the ischium containment word itself says that the ischial tuberous is contained inside the socket. If you see the previous socket, the ischium is sitting over the posterior wall. But in this case of ischial containment socket, the ischium is inside the socket, on the posterior wall. There is a transverse ridge over here, which where the ischium will be locked in this seat. So this prevents also rotation of the socket around the stump. However, there are weight relieving areas in case of ischial containment socket. These are pressure sensitive areas, as we see in case of transtibial prosthesis. In this case also, in the transfemoral prosthesis using ischial containment socket, there are definite pressure sensitive areas. What are those? These are greater trochanter, ischiopubic ramus, pubic tubercle, adductor tendon. This ischiopubic ramus, pubic tubercle, adductor tendon, these are on the medial wall. So there should be adequate clearance on the medial side to avoid undue pressure over these areas. Inguinal fossa, tip of the stump, and greater trochanter. These are the areas where these are the pressure sensitive areas, and weight should not be borne over these areas. Rather, the weight should be borne over the all the four flares, medial, lateral, anterior, and posterior flare of the stump. And this socket is fabricated with little bit adduction to a extent that it will normally simulate say a normal hip. Normal hip is bit adducted, so this simulates a normal hip, and this also stretches the abductors for its efficient function. Like here it is, the stump is little bit adducted. If you go to the quadrilateral socket, this socket is fitted with around 5 to 10 degree of flexion, and amount of flexion, it is always fixed. If there is a fixed flexion deformity, so that time that amount of flexion deformity must be accommodated in the socket by adding that amount of deformity. So this, suppose somebody is having a 10 degree of knee flexion deformity at the hip joint, and you are planning to fix a socket, quadrilateral socket to that stump, so you have to have a 20 degree of flexion adjustment at the socket level, that is 10 degree to accommodate the existing flexion deformity of the stump, and 10 degrees inherent the flexion attitude of the socket. This is how the hip flexion attitude is decided during the fabrication procedure. And this ischial socket also helps in rotation of the prevents rotation of the stump around the socket. It locks the socket stump inside the socket. So, why you are so serious about the transfemoral prosthesis? If you look to this picture, that in case of unilateral transtibial prosthesis, with the best prosthesis, 9% uses, the amputee uses 9% more than a normal person. That's a energy consumption. More 9% more than so almost if the proper prosthesis fitting in a transtibial prosthesis, he can have a normal life with very minimal energy consumption. Get they can buy ride bicycle, they can run everything, they can run, they can do everything. But if you look to the transfemoral prosthesis, in case of unilateral transfemoral prosthesis, with your best effort, still patient consumes 48% more energy in comparison to a normal person, and that increases to 200% when patient uses a bilateral transfemoral prosthesis. So, if the prosthesis is not proper fitted, you just imagine how much extra energy will be consumed by the patient, and probably patient will not work for a long period. He will be exhausted, and he will discard the prosthesis, rather he will prefer to use a cross or to travel by wheelchair. So our objective is always try to fit a prosthesis which is be less energy consuming and as near as possible as far as the gait is concerned, amputee gait is concerned. That's why today's discussion is here. So if you look to the checkout of a transfemoral prosthesis, we have to look for some broader components of the as far as the amputee is concerned. You have to look for the comfort of the amputee, whether he is very much comfortable with the prosthesis or not. As far as cosmesis, comfort, all these things also plays an important role. Then stability of the prosthesis, what is about the alignment of the prosthesis, how good it is appearing, and how best it is prepared, workmanship. So these are the things overall one should look for when you look for a checkout of a transfemoral prosthesis. So when we plan for a checkout, then we have to examine the patient in all position, general examination, check out with amputee standing, while amputee sitting, while amputee walking, and while patient is prosthesis off from the stump, and at the end, what are the gait deviations, major gait deviations observed in case of amputee while walking. So what are the general things one should look for? We should look for that what are the components is whether you have prescribed a prosthesis, whether the prosthesis is prepared as per your prescription or not. Okay, like components like whatever foot and ankle assembly you have suggested, what type of joint you have, knee joint you have suggested, what type of socket and suspension you have prescribed, whether all the things are followed or not, that we have to look for, whether the prosthesis is designed as per your prescription standard or not. That is the first thing you should look for. Like you have suggested a 4-bar linkage, and patient he has been given with a constant friction knee joint or a free knee joint. So you have suggested some form of suspension, but some other form of suspension is there. So first step is we have to see that what prescription we have given, whether the prescription is properly followed or not. That is the first part to look for. Then look for the stability of the patient. Ask the patient to stand comfortably and see whether the amputee is comfortable while standing with the midline of the heel at not more than 6 inches. So minimum with a 6 inch apart distance. If the patient is standing comfortable, then we can say that yes, this process has good stability. I mean, alignment is properly maintained and patient has good stability. So minimum 6 inch apart. If the patient can stand with both the legs, both the foot 6 inch apart, then we can say that yes, the patient has good stability. Many times patient has poor stability, and patient will adjust by standing with the abducted leg of more than 10 inch apart, like that. So the best way of examining the stability is to ask the patient to stand with both the foot 6 inch apart. If he can, then the stability is good. Then look for whether the pressure over the stump is acceptable or not. Is there any undue pressure? Is the patient is very uncomfortable with an undue pressure of any wall of the prosthesis? Ask the patient from the beginning. Then check whether the adductor longus tendon properly located in its channel or not. This is the, you can see this picture. This is the adductor channel. This is a clearance given the medial wall of the socket. So whether the adductor roll is properly fitted into that or not. Is there any excessive pressure in the anteromedial wall aspect of the socket which impinging the adductor longus? If the adductor longus start impinging, patient will have pain, patient will have discomfort, he will have a short stance gait, he will have abducted gait. Always patient will try to keep the limb in abducted position to relieve the pressure over the adductor. So you should always look for any impingement or pinching over the adductor roll. And moreover, another point is that if the fit of the adductor longus tendon into the channel, that will determine whether the socket is positioned correctly on the stump and relief and contour of the other areas of the socket are matched to the stump or not. So once the adductor roll is fit into its clearance area, the rest of the things will fall on its own place. So once that is rotated, then the rest of the things also will not fall in place. So always the first step is that look for that how the patient is standing. If the standing patient abducted way, ask the, why you are standing like this. You can ask you can ask a leading question. Do you feel any impingement over the perineal area? Look for the adductor roll is there. You will see from the back that the adductor muscle bulk will be prominent on the medial side. That suggests that impingement of the adductor roll. Next part is see whether the ischial tuberosity rest on the properly ischial seat or not. Whether if it is a quadrilateral socket, it's very easy to see that whether the ischial tuberosity is sitting on the ischial seat or not. The best way, ask the patient to bend forward. Okay, so and you put your two fingers over the ischial seat over the on the posterior wall. Then ask the patient to stand straight. You can feel the impingement of your finger between the ischial tuberosity of the patient and the posterior wall of the socket. If you feel a good pinch of your fingers on that area, that indicates that yes, the ischial weight bearing is good and ischium is properly sitting on the posterior wall of the socket. So this is a simple test to see whether the ischial weight bearing is happening or not. Okay, just ask the patient to bend forward, keep two fingers on the ischial seat, then ask the patient to stand straight. Okay, and feel the you can feel yourself the how your finger is impinged between the ischial tuberosity and the posterior wall. Then look for whether the patient the length is say bilateral, the length of the prosthesis is equal to the healthy side or not. How do you check for that? You can check it from the front side, you can check it from back side. From front side, best way, see the shoulder level, and the best way to see the both the anterosuperior iliac spine. Okay, you palpate the iliac crest, palpate the anterosuperior iliac spine, check whether the both the anterosuperior iliac spine are at the same level or not. And you can check the posterior side also, you can check the posterior superior iliac spine. If you can see the dimple of a venous on the back side, you can see whether the both the posterior superior iliac spine are at the same level or not. So that's how you can expect that is there any leg length discrepancy. Okay, sometimes you may get a prosthesis may be too long, maybe too short, and sometimes that's because of there is really true limb length discrepancy between the healthy limb and the prosthetic limb. Sometimes there is the limb length is okay, the prosthetic is well prepared, but there appears apparent lengthening or shortening of the prosthetic side. How it happened? If the prosthesis is not properly fitted into the socket, that is poor socket fit, improper donning of the prosthesis while the amputee is putting the socket, it is not keeping the socket in position. That means ischium is not sitting on its own place. Okay, or any improper alignment of the prosthetic foot. Suppose the prosthetic foot is fitted with 5 to 10 degree of plantar flexion position, so that also relatively increases the length of the prosthesis. So you have to look for that is the prosthesis is longer or it is shorter. Now look to the stability of the prosthesis. Is the knee stable on weight bearing? Okay, because weight should be evenly distributed on the both the feet. Right? So how do you check whether the knee stable or not? The simple clinical way is that just stand on the side of the amputee patient using prosthesis. Just give a small blow, strike to the back of the knee with a slight force, and observe the knee returns immediately to full extension to prevent knee buckling or not. If the knee is stable, you just give a small stroke to the back of the knee will suddenly buckle again, come back to its neutral position. If it is happening, then stability is okay. If the knee is getting buckle, that means the patient is unable to restore his knee stability. So there is something wrong at the knee joint level, which is very vulnerable for knee flexion momentum. So that can be easily assessed by drawing a drop line from trochanter to the ankle joint, that's called trochanter knee ankle line, that best check the alignment of the prosthesis, that is sagittal alignment of prosthesis for a normal person. This, if you think this is the center of rotation of the knee joint, and this is the TKA line, that is trochanter knee ankle axis line. So this line should be very close to the center of axis. For modern prosthesis, this center of knee joint can fall on the this TKA line, but for a conventional prosthesis, this knee joint or the center of the knee joint should be very close to the this TKA line, of course bit posterior. Why bit posterior? We always try that the center of gravity of the body weight should fall anterior to the knee joint, so that knee will be automatically stable in extension. We all know even quadricep is zero power. Patient can walk with a hyperextension knee, variable stability, increased with increased stability at the knee with a hyperextension, and our principle of FRO also acting on that, where the center of gravity will fall anterior to the knee joint, giving a hyperextension momentum, thereby stabilizing the knee. The same principle is applied here also, keeping the knee joint just posterior to the this TKA line stabilizes a prosthetic knee. But how far it is posterior depending upon the proximal component of the stump. With a minimum, with a medium length or a longer stump, you can say average stump, the knee bolt should be approach TK line reference very closely, as I said, very closely, right? But in case of a short stump, where you expect a leverage of the stump is poor, when there is a weakness of the hip extensors, that time that affect the knee stability. So what we should do, we should try to keep the center of rotation of the knee joint far from the back from the TKA line. More posterior it is, and there is every chance that the center of gravity will fall anterior to the knee joint. Okay, that stabilizes the knee joint. So in a case of short stump or a weak hip extensor, the knee joint should be posterior to the TKA line. If the stump is adequate length, hip extensor power is adequate, then the knee joint can be close to the TKA line. That's how one should look for a sagittal alignment checkup in anterior posterior plane. Now look to the level of the your socket, whether the posterior wall of the beam of the socket is parallel to the ground or not. This is line it is drawn. This line is normally drawn at the level of SCL tuberosity, and look for that whether this line is parallel to the ground or not. So what is the advantage of these things? If there is a tilt in the coronal plane, frontal plane, we know in sagittal plane the socket is 5 to 10 degree of flexion, but in coronal plane it must be very balanced. It should be parallel. If there is any tilt, if there is a tilt to the medial side, even 5 degree of tilt deviates from the horizontal towards medial side, it impinges the perineum. It causes pressure over the ischiopubic rami, causing pain and discomfort during using socket. If there is a tilt to the lateral side, so the lateral wall will be very much prominent. It will not come in contact with the lateral surface of the prosthesis. So weight bearing and abduction control will be poor. So all the time we should see that the posterior brim of the socket should be horizontal to the ground. So as I said that if there is a tilt in the perineum, is there any problem in fabrication, the prosthesis, and there can be possible that there will be undue pressure over the perineum. How will you say that? Whether see whether the amputee is free from vertical pressure in the perineum or not, especially the inferior ramus, that is ischiopubic ramus, and the pressure of the medial brim over the adductor roll. These two things really causes discomfort. These two are the pressure sensitive areas. This is adductor roll on the medial side, and the pressure over the ischiopubic ramus on again by the medial wall. So one should look for and ask the patient, where do you feel pain? Why are you keeping your limb in abducted position? Do you feel any pressure on the medial side? Do you feel any discomfort? Then you check on the medial wall. You will find that there may be a adductor roll or bulging of the soft tissue on the medial side that indicates that there is undue pressure over the adductor roll. Then check out the suspension strap. That's a suspension strap is more important when you use a exoskeletal prosthesis or a quadrilateral socket. Basically, this quadrilateral socket and exoskeletal prosthesis, they are suspended over the stump by a different suspension system. Like you can, this is a Silesian strap, or you can use a suspension strap with the elastic band, or sometimes in case of very short stump we use with the additional hip joint with a pelvic band. So these are three types of suspension system used in case of AK prosthesis, but very common is a Silesian strap. This is used which has a lateral attachment and two anterior attachment which wraps around the stump, around the pelvis, and this stabilizes the socket on the residual stump. So are there lateral anterior attachments to silicon the Silesian suspension is correctly located or not? So this anterior to attachment of the Silesian strap, how do you decide that? This, as I said the previous slide, draw a horizontal line at the ischial tuberous level, horizontal line. Draw another vertical line on the midpoint of the anterior wall. Okay, so this is the center point. So this attachment of this anterior attachment of the Silesian strap should be equal distance from these 2 points. So what will happen? Is there any disturbance in the attachment? If there is a distal attachment towards more distal, it causes adduction of the stump. So there will be the limb will remain in adducted position. Okay, if there is a changes in position of this, in either the strap is anteriorly placed or posteriorly placed, that also causes a rotational deviation, because this rotates. Suppose the one is posted anteriorly, one fitted posteriorly, that creates a torsional force during walking, and that creates a gait deviation with medial and lateral rotation of the limb around the vertical axis. So this plays an important role also for forward progression of your prosthetic limb. Now after standing, let us see the what one should look for when the amputee is sitting. So look to this picture. Here the amputee is sitting. So what you should look for? Sitting comfortability without pinching. If you see, if this anterior brim of the socket is impinging to the belly of the patient, he cannot sit 90 degrees. So he has to go for ischial sitting and just bending backward to relieving pressure by impingement of the anterior wall to the abdomen. Okay, this is one check. Second check, adequate check, ask the patient to lean forward to touch his toes, prosthetic toes. If he can bend forward touching his foot, that means adequate clearance is there. Okay, so these are the two important things one should look when patient is sitting. Okay, and second thing, check for whether the socket is closely fit, the lateral is closely fit to the stump or not. Many times if this is not properly fitted, the socket will just loose come out while sitting, and you will have an excessive gap on the lateral side of the prosthesis between socket wall and the stump. So these are the basic things you should look for. So this shank should be 90 degree placed to the thigh component or the socket component, and it should not impinge to the anterior abdominal wall. What other thing I should look for? Does the shank remain in a good alignment, whether it is vertical to the floor or not? Is there sufficient clearance between thigh and shank? to allow 90 degree of sitting position. That means if you give a cover here in modular, or in case of conventional or exoskeletal prosthesis, if the shank component touches to the hit to the socket component, it will not allow 90 degree of flexion. If the patient can comfortably sit 90 degree position with shank in vertical to the floor, that indicates the adequate clearance is there between the shank and the socket. What other things one should look for is the if there is a prosthetic knee joint higher than the sound leg, then shank is too long. This suppose this knee joint is above the, this is normally anatomy, this is mechanically. If the prosthetic knee is higher than the sound leg, that means this joint will appears here. That indicates that the shank is too long. Okay, if the prosthetic is lower, then the thigh component will protrude out like here in this case. In this case, if you look to this joint and to the knee, the thigh component, the anatomy, the mechanical knee is protruding forward in comparison to the anatomical knee. Okay, and shank appears smaller than the other side. In a small shank, the knee will protrude anteriorly, and if you see the level, the anatomical joint level will be higher. Okay, so that's how you can see that is there in a disproportion between the thigh length and the shank length. Although the prosthesis appears equal length on both the side, but if you ask the patient to sit, you can see is there any discrepancy between the socket length and thigh length and position of the knee, whether the anatomical knee is corresponding to the mechanical knee or not. That you can see, you can check clinically by asking the patient to sit on a chair. Then ask the patient to stand from sitting position. Sometimes you will find abnormal hissing sound coming out when the patient either sit from standing to sitting position, or standing from stand to sit or sit to stand. Why does that happens? There may be air leak, especially in case of total contact sockets. So that times suction socket, you will expect some air hissing while standing to sit or sit to stand. And other source of noises you can expect from the foot ankle assembly, can be from the joint, knee joint, can be any, if any external hip joint is given, there also you can find some noise. So that indicates a poor workmanship or poor fitment of prosthesis. Then it has to be returned back to the prosthetist to look take care of these things. Now after sitting, let us check the amputee while walking. Any major gait deviations while walking on level, while walking on uneven surface. If the suction is maintained during the walking, there should be no piston action. If the socket is loose, each time patient bears weight, the stump goes in, and while walking again the prosthesis, the weight is coming down. So it could be a poor fitting socket, it could be a poor fitting suspension. So there you will always have a piston action while walking. Check the patient whether the patient is comfortable while going down or climbing up in stairs. Does the lateral wall of the socket maintain the form and even contact with the lateral aspect of the stump? Each time the same thing is repeated, because the normally the stump is aligned with little amount of adduction, so that needs a close contact with the lateral wall with the lateral flare of the stump. So these things also need to be taken care of. Next is swing phase of the amputee gait. We have what are the things we should look for? That heel rise adequate to clear the ground, whether the patient is dragging the foot on the surface. Prosthetic knees bend smoothly during walking. Leg swings forwards with adequate knee and hip flexion. Knee extend before next heel contact. Stride length should be equal to the on both the sides. So these things you take a video and go for a small slow video. You can see, you can gradually see that how the foot is moving. It is moving. whether he's going to it's going to knee flexion during swing phase or not, whether he has a normal heel strike. You can see in this case he has a good heel, she has a good heel strike, starting the heel strike. So she doesn't have a quick foot flat, she's going for a gradual foot flat, right? So these things, take a video, you can analyze the video as we go for a observation and gait analysis. Same thing can be applicable in case of prosthetic gait evaluation. Now, the next part is that check with the prosthesis off. Ask the patient to take out the prosthesis from his stump and see is there any excessive pressure, excessive perspiration over the stump, and check is there any discoloration caused by excessive pressure over the prosthesis. If any areas of redness or discoloration which disappears within 10 minutes after removal of the prosthesis, that is not a big problem. These are not usually significant. If that discoloration or redness persists for more than 10 minutes, that is really a sustained pressure is going on over the socket, and you have to ask your prosthetist to give clearance or modify the socket to avoid undue pressure. That pressure may land with a pressure ulcer, or the ulcer over the socket by the pressure of the ulcer of the stump by the pressure of the socket. So that's the best way to see that is there in undue pressure. You can see also pressure marking by the stump socks. That also give you idea that yes, undue pressure is happening. Workmanship, though, you have to watch and supervise the work of the prosthetist, see whether everything is properly fitted or not, if the repeats are well fitted or not, if the strap is well fitted or not, is there any creases over the innards of the socket which can give rise to a undue pressure. So these, the rivets and all the fastenings are well secured or not. So these things one should look for the overall workmanship of the prosthesis, whether good and cosmetically acceptable or not. And the amputee satisfaction is paramount. Unless amputee is not satisfied, then probably he is not going to use the prosthesis. He will either he'll go to other place to have a new prosthesis, or he will prefer to move with either a crutch, a pair of crutch, or using a tricycle or wheelchair. So always we should look for the comfort, function, and satisfaction of the prosthesis, the amputee using the prosthesis. Now the last part is the gait deviations in transfemoral prosthesis. What are the common gait deviations we should look for in case of AK amputee? So the commonest, if you divide the different components of the gait, that initial contact to mid stance, then mid stance to toe off, then in swing phase. So if you analyze the different stages, gait deviation, different stages of the gait cycle, the initial first part is the initial contact to the mid stance. The commonest problem the patient face is the knee flexion. All of a sudden patient will have a knee flexion attitude. He will start move like this. So he will have a all of a sudden knee flexion, and he will drop, the knee will drop down while walking. So what are the possible causes that one should look for, that maybe some problem in the prosthetic fitting which give rise to these types of knee buckling? That is inadequate flexion in the socket, limiting active hip flexion. Patient is already having hip flexion deformity. If that is not accommodated inside the socket, or if there is a weakness of the hip extensors, and you have not taken care of the position of the knee joint with respect to TKA line, so that can give rise to a buckling of the knee in the initial contact to mid stance phase. So in that situation, the look for the position of the knee joint, it's always that it should be posterior to the TKA line. And next thing one can give rise to this type of knee buckling is the too hard heel cushion. Normally, why you use a sarge foot? It is sarge foot is a cushion, having a cushion heel which simulates the plantar flexion. Once the patient go for a heel strike, the rubber in the heel area will get compressed, and that simulates a plantar flexion. If the heel is too hard, there all of a sudden dropping of the foot, either the limb will be rotate or will have a sudden buckling of the knee. So these two things should be checked for the amount of hip flexion contracture, the power of the hip extensor, the type of heel cushion in case of prosthetic foot, and position of the knee joint. All these four things should be look for when you go for a knee flexion, when you go for a gait evaluation, gait deviation seen in initial contact to the mid stance phase. I hope it is clear that the position of the knee joint which gives the stability in the stance phase. Then another possibility in this stage is the foot slap. All of a sudden, there will be slapping of the foot. Look to this picture. This patient left side prosthesis, there is no transition of the heel strike to mid stance phase. Heel strike, full foot flat, mid stance. That straight way after heel strike immediately is going to the slap. So this has to be avoided. What are the possible causes? If the plantar flexion resistance is too soft, if it is too soft, if it is too hard, it affects knee. If it is too soft, or instead of gradual simulation of plantar flexion, all of a sudden there will be plantar flexion. If the heel lever arm is too short, that means the end of the prosthesis heel is to midpoint of the foot, or there is a possibly driving foot into the quick flat to assure extension of the knee. Patient have a quick trick movement, plantar flexion to stabilize the knee in extension. That is done by the patient trick movement at the stump level to stabilize the knee joint. He tries to drop the foot quickly. So as soon as the foot drop quickly, the CG will come to the front of the knee and stabilize the knee. So that is an indicator that the foot slap is indicator of this deficiency, like excessive soft heel or a problem in the trick movement is adopted by the patient to stabilize the knee. Then coming to mid stance phase, the very common this type of problem we see mid stance phase is the lateral trunk bending. Lateral trunk bend is common in AK prosthesis. All AK prosthesis they work with a little bit lateral trunk bending. But if there is excessive lateral trunk bending, then there might be some problem in the prosthetic fitting. Either the prosthesis is too short, causing the hip drop to the same side. When the prosthesis is short, the patient will limp to that side with a lateral bending in the trunk. If it is inadequate adduction angle of the lateral wall, it is from the beginning I'm saying repeatedly the lateral wall should be adopted. If it is inadequate adduction, then also patient deviate is strong to the lateral side during the stance phase. If there is a high medial wall, if this side is impinging, patient will try to bend the trunk to the prosthetic side to relieve pressure on the medial brim of the socket. Okay, so these are a few things which can give rise to lateral trunk bending. Other things are very short stump that fails to provide sufficient amount of lever arm for maintaining the stability at the socket and stump contact. So short stump also patient tried to stabilize the prosthesis by lateral bending to the prosthetic side. Painful stump. Patient tried to avoid weight bearing and with a quick short stance phase, it tries to bend to the prosthetic side. Weak abductors, weak abductor, either adduction of the wall, poor adduction of the wall, or weak abductors also can lead to lateral trunk bending. And sometimes everything is fine, but still patient walk with a lateral bending. That's a bad habit of a person. They have habituated to walk with a lateral bending. Mostly seen in case of second time users. Everything is fine. Still patient walks with a lateral bending. That's a poor habit pattern by the AK prosthesis. Then abducted gait. This is another common gait seen in case of amputees. They walk with the abducted base. It's very simple. Why? There may be abduction deformity at the hip joint, or as I said earlier that there the medial wall may be pinching. That's why he's trying to keep the limb in abducted position. That's in a high medial wall. Okay, and there may be improper fabrication and not maintain the normal adduction angle. Normal adduction angle should be maintained. If that is not maintained, if there is abduction contracture also, that is possible. Or the pelvic band is too far away from the patient's body. Also, that pulls the stump and prosthesis laterally, that causing a abducted gait. So too long prosthesis, high medial wall, improper fabrication procedure with poor adduction angle, abduction contracture at the stump level, and there is a pelvic band attachment, wrong attachment of pelvic band. So these are the conditions where patient can have a abducted. You just analyze, it's a very simple thing. Either this side is impinging, try to patient trying to keep the limb in abducted position, or some pathology in the lateral side contractors, abduction contractures like that. Okay, or a too long prosthesis patient try to accommodate the limb by either circumduction or abduction gait, like as we seen in case of hemiplegic also. Okay, so these are the causes of abducted gait. Then coming to the next phase of the gait is the mid stance to heel up. In this, the common gait abnormality is the vaulting. Vaulting means patient will hip up, try to lift that side of the pelvis up to clear the foot from the ground. Patient tries to raise the toes on the sound side, a healthy side, to swing the prosthesis. So what are the possible? The best way we can see that maybe the prosthesis is longer. So he is trying to clear the ground by elevating the outside the pelvis by standing in the tip of the toe on the healthy side. So what are the possible causes? If the prosthesis is too long, it may be true, really too long, or maybe apparently too long. Apparent too long means the socket is not properly fitted. It's not properly done into the stump. So and the suspension system is not properly working. While swing phase, the this is coming down. So the length of prosthesis is apparently longer, and patient try to clear the ground by elevating the hip on that side. So inadequate suspension, excessive knee friction also. That means it is in the in swing phase, it is supposed to go to from extension to flexion, but the flexion is not happening. So what will happen? The patient will try to clear the ground by hip up, by vaulting. Then locked knee. Locked knee, again the defective knee joint, but the knee is locked, is not going to flexion. And third one is habit. Again, some patient have a habit of walking with a vaulting nature. So abduction gait and this vaulting, these are some of the common bad habits of the people, prosthetic users. Circumduction gait, the same as we in circumduction gait we see in hemiplegic, because inadequate knee flexion, because of the limb appears the apparently longer because of lack of knee flexion. So too long prosthesis, patient will try to clear the ground by circumduction. Too long prosthesis, difficult knee flexion due to the posterior alignment of the knee joint, too much of friction in the knee joint, that means the inadequate flexion is happening because of friction in the swing phase. Any abduction contraction trying to swing the limb in the abducted way to put it in the front, and fear of stubbing of the toes. Some people, they fear that the toe may be, because that's not a normal toe. The prosthetic, they inserted foot, so they feel that maybe the prosthetic foot is dragged on the floor or is impinged on the floor, the stubbing on the floor. So to with that idea in their mind, they try to circumvent to clear the ground. So what are the possible causes? There may be poor hip flexor. We need a good hip flexor for the ground clearance. As we don't have, in case the natural knee flexors are not here in the knee, so patient try to clear the ground by flexing at the hip joint level. If that is not there, hip flexors are poor, so patient will have a circumduction gait. Foot is plantar flex. Again, that increase apparently lengthening the length of the prosthesis. Again, for the clearance purpose, patient will try to go for a circumduction gait. Loose socket and suspension, as I said earlier, that the socket, the prosthesis will drop down with its weight during the swing phase, and giving rise to a upper lengthening of the prosthesis, prosthetic side, and patient try to clear by circumduction. Medial hip or lateral hip, I have not shown the picture, but the thing is that here the lateral hip, medial hip means the patient move his limb with either prosthetic internal rotation or prosthetic external rotation. So that is seen in case of excessive internal rotation of prosthetic knee, or excessive rotation of the external rotation of the prosthetic in medial hip. So this excessive rotation at the knee joint level, even at the socket and stump interface, will give rise to a medial or lateral whip. Patient move forward with either internal rotation prosthesis or external rotation prosthesis. There are other association factors are excessive valgus, excessive varus at the prosthetic knee joint, and applying the prosthesis with internal or external rotation during donning of the prosthesis. And third thing is that if the silesian strap is not properly fixed anteriorly and posteriorly with the equal distance, so that can give rise to also rotation of the prosthesis, giving rise to a medial or lateral whip. Sometimes uneven arm swings and uneven steps are marked in case of prosthetic users. Arm on prosthetic side held close to the body rather than a free swing when if there is improper fitted socket, unstable knee, improper training, fear, habit pattern. This fear factor is there always in rest of the things. Body patient will be very cautious about the prosthetic gait. Is the knee will get buckle, or is there is a instability at the hip joint. So these try to walk with a very cautious gait with close arm to the prosthesis. That is the uneven arm swing, whereas on the healthy side you will have a normal arm swing. So you will find a uneven arm swing in the initial all new fitting prosthetic users. Uneven steps, you can see short stance on the prosthetic side when there is socket discomfort, when the insufficient knee flexion. So patient try to shorten the stance space as the stump is painful, or if there is a socket discomfort like perineal impingement, adductor roll impingement over the ischiopubic rami. So these things patient will try to avoid stance space with a very short stance space, that giving rise to a uneven step length in the normal gait cycle. So these are the basic things one should look for as far as the prosthesis itself examination and during evaluation the gait while patient is walking or sitting or standing with prosthesis. There is a definite prosthetic checkout form where the everything's to be mentioned: what type of prosthesis, what type of amputee, what was the initial checkout, what problem was detected, and how it was subsequently cleared, and when final checkout is done, whether all your requirements are fulfilled or not, whether the patient is having a near normal gait or not, that is done at the final checkout. And finally, the before signature, we have to see that everything, whatever prescription, everything there in that prosthesis, and patient is working with a near normal gait. So this is all about the checkout and gait deviations in transfemoral prosthesis. I hope I have covered the most common and important part of that. There are so many other deviations are there also, but these are the common things one should remember or can analyze. Once you look to that, we also don't find that much of time or giving so much of stress for evaluating prosthesis after ADIP issues there. Nowadays there are different portal, the patient directly going for checkout at the portal level. So many times we don't also get chance to completely evaluate the prosthesis in the department. Thank you. If there is any question, we can discuss. Arun,
Sir, there is a question in chat box.
you can ask the question. Read out the chat box and ask me.
Yes, sir. What type of knee joint is prescribed in long transfemoral residual limb?
The base socket for a long prosthesis is, if you go for advanced form, all advanced sockets are the ischial containment sockets. So in ischial containment socket, many designs are coming up now. So there may be you have a soft socket inside, soft liner, and outside is a hard socket, and many modifications can be done with the ischial containment socket. So whatever the length size of the stump, that ischial containment socket is always better. But in case of places where the facility of ischial containment socket preparation is not there, long sockets can best work with a quadrilateral socket.
Sir, is there any particular wheelchair prescription in bilateral transfemoral amputee?
Wheelchair prescription for bilateral?
Transfemoral amputee.
I don't think so, but only the we have to see the trochanteric length, whether both the trochanterics are clearing to the wheelchair sides or not, about the armrest, but nothing concerned about the footstep or the footboard or height from the ground to back of the knee. So if the prosthetic patient is using prosthesis, then we'll always encourage the patient to use a prosthesis. But when patient using a wheelchair or tricycle, I don't think that the prosthetic bearing is required for that. For transport purpose, they can use. But the same way with prosthesis, if you want to check out with a wheelchair, then the formula we use for clearance of the knee, the foot position, everything will be same as for a normal person.
Sir, what are the common causes of low back pain in amputees?
Low back pain, it is same as if there is any gait discrepancy in that. What I mean to think that it is not directly related to the amputee. If there is a gait deviation in the amputee, suppose patient is walking with a always lateral, two lateral bending gait, so you will have a in long run you will have back pain, obvious back pain. Patient is having with the abducted gait, all types of gait deviation, because in a key prosthesis very close to the spine. It is because whatever gait deviation it will affect the hip joint, and once hip joint is affected or biomechanically hip joint is affected, it indirectly affect the spine also. So the commonest problem the patient have, that is lateral trunk bending. A prolonged excessive lateral trunk bending can give rise to back pain in long run.
Yes. Sir, one more question. Sir, want to know knee joint prescription in long transfemoral residual limb. Knee
Long
joint
term, yes, you
prescription.
have to see that the space requirement for 2 inch space requirement for fitting of the mechanical joint is available or not. So if it is a through knee prosthesis, you don't have that scope. So the joint will be well below the knee joint. That's why in a case of transfemoral amputation, when you are planning for doing a AK amputation, better to go for the supracondylar area, keeping 2 inch space for accommodating the mechanical knee, so that the mechanical knee will correspond to the anatomical knee. If the long stump is too long, that is not accommodating the knee joint, so maybe you will have to go for a constant friction knee joint, external knee joint, which can be adjusted to the normal side, anatomical side. But if you go for any mechanical knee joint, that is either 4 bar linkage very commonly used, or other microprocessor knee, they may require very small area for accommodation knee. That time it may create problem. So in a long term, patient can afford, can go for a higher socket with the better types of knee joint like microprocessor knee, where the very small space is required for fitting a mechanical knee joint. But if that facility is not there, you are forced to use a 4 bar linkage knee joint which is available under ADEP scheme. That situation you need to have a amputation of the supracondylar area around 2 inch clearance must be there to accommodate the mechanical knee. If that is not there, the knee joint will be always prominent from the comparison to the anatomical knee joint, and while sitting patient will feel discomfort.
Sir, socket and suspension preferred in residual limb with grafted skin.
Grafted skin, whether where area, if the sensitive areas are there, the grafted skin, so we have to give clearance in the stump. The suspension system has a limited role in that. So suspension role is to keep the socket in place or in contact with the stump. So it has no direct role. If there is in a very short stump, yes, the sockets, the suspension system has a role. You have to give a external hip joint, you have to give a pelvic band around the girdle, so that it will stabilize the hip joint. But as far as the skin graft is concerned, you have to modify your socket, you have to give clearance on that side, because femoral sockets are mostly total contact sockets, except a conventional socket like quadrilateral socket. But the commonest ischial containment sockets are almost all are total contact sockets.
That's all, sir. No more questions.
So, if there are no more questions, then we can wind up the session. I hope the session will be useful for the students, especially for their examination purpose, and bit idea about the how to evaluate a transfemoral prosthesis. And this is the small child fitted in our institute maybe a long back with AK prosthesis. In the small child, we don't give any knee joint as in case small child in orthosis prescription also the joints are not provided. Here in this case also a prosthesis is fitted with without knee joint. Uh, as the child grows, he is aware about the different gait. I mean how the normal person works. That time knee joint can be fitted. Thank you all for joining with us. I must thank the office bearers of IAPMR, especially the PR team, for providing us the Zoom platform for carrying this academic webinar. And I must thank my friends and my PG students of my department and the office bearers of APMRO for cooperating us and encouraging us for organizing such type of webinar. Thank you very much. Good night.